Hello and welcome back to Breaking the Consensus here at Protect Life. And I'd like to thank you all for joining us tonight for this webinar. Before we start, I'd like you just to remind you that you see the little subscribe button there. If you want to click on that, it means that any materials that are coming up, any new material we have, will come directly to you. Also, as you know, we are still engaged in a lot of battles here, a lot of fights for the life issues that we all share, that we still have to go forward, even in the midst of the pandemic. So any help you can give us, any donations, if there's a donate button there, whatever you use, we can promise you will be used carefully and will be used well. Tonight, we have the great good fortune to be talking to Dr. Tony Levatino. Tony Levatino is a very prominent, well-known advocate for life in the United States, formerly practiced in OBGYN and in abortion. But has for many years now been an advocate for life. I'm sure many will have heard of him. Thank you, Tony, Dr. Tony Levatino, for joining us.
Happy to be here, Michael.
Thank you. So we have a lot of questions already in, and one of a lot of the questions are looking for basic technical information from a person they can trust. We've had a lot of discussion in the period up to the repeal of the 8th Amendment here, and a lot of obfuscation maybe about things. So what people would like to understand, for example, what we mean by a medical abortion as opposed to a surgical abortion. And we're aware that approaches and methods change in the first, second, and third trimester. So if you could address that, I know it's a big issue, but we have the time, but you could explain to the people, as the pregnancy progresses, the different methods that are used, and what are the issues for both for the woman and obviously for the child, and the complications and issues that may arise.
Okay. Well, pregnancy is divided into 3 trimesters. From the last period that a woman has until she is due is 40 weeks. So we divide it into 3 more or less equal parts. From that last menstrual period to 13 weeks later is the first trimester. The second trimester is from 13 to 27 weeks. That's where we add the extra week to make it work. And then from 27 to 40 weeks is the third trimester. The procedures that are used for abortions in some ways almost track that trimester framework. It's just the way it works out in terms of the technology. So if we're talking about first trimester abortions, in the United States, 90% of all abortions are done in the first trimester up to 13 weeks from the last menstrual period. And there are 2 basic methods that can be used. The majority of first trimester abortions are done by suction D&C, and I'll describe that in a minute. At this point, the numbers are increasing, but at this point in the United States, about 40% of first trimester abortions are done with medical abortion. A medical abortion is an abortion that is performed by prescribing a series of medications. There shouldn't even be controversy about how this care is provided, but there is here, even though abortion has been legal in the United States for almost 50 years. But basically, a medication called mifeprex or mifepristone, which is made by a company that was specifically organized to distribute it, is a company named Danco, is the first medication that's given in a medication abortion. Pregnancy, in a normal pregnancy, the cyst where the egg originally came from forms into something called the corpus luteum cyst. That produces progesterone that keeps the pregnancy intact and attached to the uterine wall. Mifeprex or mifepristone interrupts the action of progesterone and cuts the connection basically between that baby and the uterine wall, which is, essentially it disrupts the blood flow to the baby. A second medication called misoprostol is then given 24 to 48 hours after the dose of mifeprex or mifepristone, and that stimulates uterine contractions to expel this now dead baby inside the uterus, this dead embryo inside the uterus. It's easy. Now, there's been a lot of emphasis on medical abortion here because you don't need any surgical skill to perform it, but it has created its own problems. We are constantly told in the States how safe abortion is. Like, it's no different than any simple medical procedure, but it's not that simple. We're talking about killing an unborn fetus, and when you give that second medication to expel it, there can be complications. And despite the fact that they keep emphasizing how safe it is, there definitely are complications associated with it. 8 to 9% of the women who undergo a medical abortion bleed so heavily they end up in an emergency room. And many of them require a surgical DNC to complete the abortion. It's possible for the medication simply to not work. It is possible to get infections with medication abortions. There have been deaths reported from medication abortions in the United States. The second, and that gets into another area because, and we can talk about this in a minute if you wish, but the vast majority of obstetrician gynecologists in the United States will not perform abortions. And this is, I think, really concerns the politicians and the healthcare providers who believe in abortion as some kind of healthcare, that, you know, you can have a right to abortion, but if you don't have anybody who's willing to do it, that restricts it, and that becomes a point of difficulty. And so the trend in the United States is to allow non-physicians to prescribe these medications. Well, that may seem simple enough. All I have to do to perform an abortion is write a prescription. But when upwards of 10% of my patients are ending up in emergency rooms with heavy vaginal bleeding or hemorrhaging because of my procedure, much less the other complications, well, who takes care of them? And what ends up happening is these patients are being dumped, and I use that word deliberately, dumped, into emergency rooms to allow and to force other physicians to take care of the complications. This is not good medical care. If your wife came into my office for a hysterectomy and I performed the hysterectomy, and then 3 days later she had a fever or was hemorrhaging from the vagina, how would you feel if I said, well, I'm not taking care of you, just go to the emergency room, let them take care of you. I'm not going to have anything to do with that. That's not ethical. That's not good medical care. And that's often what's happening, especially with medical abortions.
Sorry, in the case of medical abortions, in the sense that they can be safe at all, is there an upper time limit? So what I mean is there also a risk that, in a sense, that women are going to self-diagnose the point at which they're in their pregnancy, and if they get that wrong and they use a bit, that can be problematic?
Absolutely. Originally, when Mifeprex was approved in the United States, it was allowed to be used up to 7 weeks, 42 days after that last menstrual period. Several years ago, based on some new data, they changed it to 10 weeks. Now, and again, because there are so relatively few physicians who will perform abortions, now the emphasis is on telemedicine. I talk to you on a video connection, just like I'm talking to you now. And then I decide, yeah, you're okay to have the abortion, and I send you the medication and tell you how to use it. Excuse me, but you need to see a patient and you need to examine that patient to be safe. First off, how do you know it could be used up to 10 weeks? I don't know how far you are in your pregnancy. You may think you know when you got pregnant, or you can tell me when you think your last menstrual period. But when I was doing abortions, we did ultrasound on every single one of our patients for 2 reasons. And we did, as dedicated as I was to doing abortions, we did ultrasound on every one of our patients for 2 reasons. One, I want to know exactly how far along you are in the pregnancy. This is a safety issue. If I think you're about 8 weeks pregnant and I'm going to do, say, a DNC in my office, and it turns out, and I start the DNC, and it turns out that you're really 12 weeks pregnant or more, I'm in trouble, and you're in trouble, because an office setting may not be the appropriate setting for doing a later abortion, and I'm not set up or prepared to do a later abortion. Mm-hmm. The other thing is, and this is particularly critical with medication abortions, There is a definite percentage of pregnancies that are ectopic. They are not in the uterus. They're in the tube or other places, but usually in the tube. The use of medical abortion and mifeprex is absolutely contraindicated and is not safe for use in an ectopic pregnancy. If I don't examine you, if I don't actually see you and do an exam, and if I don't do, and the only way to be sure, to be reasonably sure that someone does not have an ectopic pregnancy is to do an ultrasound. An ultrasound should be required. So it's a little schizophrenic. The regulations, the certifying documents in the United States for the abortion pill say that you must rule out an ectopic pregnancy, but they do not require an ultrasound. But the only way to reliably rule out an ectopic pregnancy is to do an ultrasound. And this becomes a problem. And there have been deaths in the United States from undiagnosed ectopic pregnancies that have subsequently ruptured, and these patients can hemorrhage to death, and this has happened.
Here, the advocates who are saying that the pro-abortion advocates were saying that largely the introduction of abortion here would be general practice led, GP led, and it would be based on medical abortion. It was pointed out, they said, well, hold on, for this to be safely practiced, you're going to have to be able to perform a scan. Most GP practices don't possess the technology, and even if they had the technology, there is actually a skill, I'm told, in reading a scan. Not everybody can read a scan accurately. And therefore, to pretend that this is a simple and therefore safe procedure that you can do with your GP is being, at the very best, disingenuous. Is that right?
I believe that because, as I said, if you do an ultrasound scan and you see a pregnancy in the uterus, then in most cases, you've effectively ruled out an ectopic pregnancy. That's great, but you have to do the scan. And as you say, the majority of general practitioners do not own ultrasound machines, which means if they were practicing good medicine in terms of doing a medical abortion, in my opinion, these patients should be sent out for an ultrasound to rule out ectopic pregnancy. That's absolutely true.
Okay, so you said in 10% of cases, in this very safe procedure, 10% of the end up in hospital with problems regarding hemorrhaging.
8 to 9%, up to 10%. Yes, end up in emergency rooms. Yes.
Okay, so that's not the most common up to now. Because of the difficulty perhaps in finding practitioners. Maybe this is being expanded, but up to now, it is still not the most common method for abortion in the first trimester, you were saying.
It is not. In the past, when I was doing abortions, we didn't have medical abortion. So all of my first trimester abortions and all my experience in first trimester abortion was a suction D&C. Now, it's a surgical procedure. It's not an extremely complicated surgical procedure, but it does take a level of skill to perform, certainly. The cervix is dilated or opened. A suction catheter is put through the cervix into the uterus, and it's hooked up to a suction machine that you then turn on. This provides a suction action that tears the baby apart and pulls it into the machine, and it draws out the baby and the placental tissue and the fluid. And then when that's completed, most doctors, I did this, would do a scrape of the lining to make sure that it was actually empty. This has an advantage. I mean, where a medication abortion can lead, as I said, 8 to 9% of the time, end up with a patient who's hemorrhaging in the hospital and ultimately ends up in needing a D&C anyway. The D&C abortion is almost a sure thing. I mean, unless you perforate the uterus or miss the cavity entirely, which is harder to do, can be done. It has happened, but the vast majority of time, it's much more straightforward. It doesn't take days to perform. And you know that and the other problem with medication abortions, the patient has to come back in a week or two and be re-examined to make sure that the abortion occurred and that it was complete, that all the tissue was extruded. With a suction D&C, you're almost guaranteed that all that tissue has been removed in the vast majority of cases when you do the procedure, because any tissue that you obtain gets sent to a lab and is examined. And again, in this case, and you're again, and not only does that, it reassures you that you got the baby, the products of conception, but also if you do a D&C, remember I said you have to always rule out an ectopic pregnancy. Yeah. A suction D&C won't end an ectopic pregnancy, but if I get tissue from the uterus, send it to the lab, and it says there are no baby parts in here. There's no pregnancy tissue in here. Now I've been alerted. Aha, the pregnancy is somewhere else. So you see, the D&C is a surer procedure, and it by its nature it rules out the ectopic pregnancy when that tissue is examined. So that's what a suction D&C has done. And as I said, I've said in the past, I understand why there's a push for medical abortion, because it doesn't take any skill level. It doesn't take manual skill to write a prescription. But it always begs the question and introduces the concern, yes, but if she has a complication, who's going to take care of her? And it should be the doctor who did the abortion. You did the procedure, you collected the fee, you should take care. I mean, that's just basic medical ethics. You do a procedure on someone, you take care of the complication. Or at the very least, you have a transfer agreement with another doctor to take care of the complications. You know, if you have problems after your medical abortion, I don't have privileges in the hospital, but Dr. Smith, who works at this hospital, will take care of you. Fine, I'm okay with that. But you don't just dump them in the emergency room and simply have someone else involved with it who knows nothing about the patient, has no medical records. It's not good medical care. But anyway, that's what a suction D&C has done, and it's done up to 12 to 13 weeks. So people who are listening understand when we're talking about the first trimester, a 12-week embryo, 12 weeks from last menstruation, look at your hand, the width of your hand from head to rump, not counting the legs. That's how large a 12-week fetus is. So you can do a suction D&C up to that size, about 12 to 13 weeks. Medical abortion in the United States is approved up to 10 weeks, which is somewhat smaller. That's a fully formed baby. And keep in mind, at 10 weeks, if you look at a baby on an ultrasound, they're kicking and moving actively.
So, I mean, but at least in this case, when you evacuate what euphemistically called the products of conception, there's nothing recognizably human in that, is there?
Oh, no, that's not true at all. Excuse me, that's incorrect. When you do a suction D&C, it's very important. I've said this 100 times. Whenever you do an abortion procedure, and this is something else that makes medical abortion somewhat problematic. Somebody takes medication, and essentially you induce a miscarriage. You cause a miscarriage. 9 times out of 10, she's in her bathroom on a toilet and passing this tissue. And what's the first thing she's going to do? You know, in a suction D&C, I have that. Me, the doctor, I have that tissue, and I send it to be tested. When she has a medical abortion and she's in her toilet, what is the first thing she does? She reaches for the handle and pulls, and that tissue disappears. In a suction D&C, when I do in a suction D&C or in late-term abortions, which we can talk about, the doctor has to keep inventory. You have to make sure that you get 2 arms, 2 legs, and all the pieces. Because if you don't, if you leave tissue behind, your patient will come back infected, bleeding, or dead. And I've said that many times. You do a suction D&C at 9, 10, 11, 12, 13 weeks, even 8 weeks. You look through the machine, all that tissue goes into what's called a stockinette. It's just a little bag, basically, that all the tissue goes in. When you're done with that suction D&C, you open that bag up and you make sure you've got fetal parts in there. And trust me, you can see arms, legs, rib cages, heads in that mix. It's not just this baloney that people are told about abortion. Oh, it's just a blob of tissue. That is not true. At 10 weeks, your baby has a heartbeat 6 weeks from your last menstrual period. All right. Only 2 weeks after you miss your period, your baby has a heartbeat. At 10 weeks, that baby's actively moving. You can see this on an ultrasound anytime you want. At 12 to 13 weeks, that baby is as big as the width of your hand and actively moving. So no, when you do a suction D&C, you can see pieces. And you need to look because you need to take inventory.
Is that hard?
You know, people ask that all the time. Sure it is. But you can get used to anything. I mean, a human being can get used to anything if they do it often enough. And that includes this. You know, in a suction DNC, yep, you see little arms and little legs. And that, I mean, if you have any humanity at all, that affects you. You see that. You're not an idiot. You're a doctor. You know what you're doing. And when you get into late-term abortion, I'll discuss that in a minute. It goes up to a whole different level.
So that's the first trimester.
That's the first trimester.
Suction DNC and medical abortion. After the 13th week to the 27th week, we go into the second trimester.
Correct. The second trimester abortions are, now, there is a lot of medical literature out there, even though Mifeprex, this abortion drug, is used in the United States and approved for use up to 10 weeks. There is more and more research coming out to use it in later and later stages of pregnancy. Now, again, this becomes problematic when someone, even though it's not approved for that yet, there's research going on in it at this time. But imagine, it's something very important about abortion generally. This is a medical procedure. There are possible complications, infection, bleeding, we've talked about, perforation of the uterus, having an instrument go through the uterine wall. You could lacerate an artery. There have even been deaths from abortions. This is a medical procedure and it has complications like all medical procedures have. But it is very well known and very, very well documented. The risk to the mother of an abortion goes up by approximately 30% each week she gets farther and farther in her pregnancy. Now, it's really interesting. In the United States, the maternal mortality rate, the chance of death just from having a baby, has been going up for years. It's up to, I think, 13 or 14 per 100,000 patients. Every 100,000 patients in the United States that deliver a baby, 12 or 13 of them will end up dead. Ireland has been extremely well known, is known the world over as one of the places where the obstetrical care is the highest quality in the world. And it's reflected in the very low maternal mortality rate you have in Ireland compared to the United States. The maternal mortality rate just for delivery in Ireland is half or even less than in the United States. And this is important because as the length of gestation increases, as the baby gets bigger and bigger, and you try to do an abortion, it comes a point, abortion is safe. This is all they want to hear. And this is all they say. It's a nice, simple soundbite. But the reality is that even in the United States, the risk of an abortion to the mother, now let's not even talk about the baby. The risk to the baby is 100%. He's going to die. But the risk of mother dying of an abortion at 16 to 18 weeks in the United States is the same as the risk of her dying from childbirth. And if it gets even bigger, her risk of dying is higher than if she had given birth to the child. In Ireland, where you have a maternal mortality rate that's half of what we have in the United States, there comes a point somewhere in the second trimester where the risk to the mother of dying is actually higher if she gets an abortion than if she delivered the baby at term. And that doesn't even count other problems that occur. Okay. So when you're talking about a second trimester abortion, we talked about 13 weeks as a little bit bigger than the width of your hand. I did second trimester abortions up to 24 weeks. Now remember, I was doing my abortions back in the early 1980s. I stopped in 1985. And at that, in the early 70s, when abortion was legalized in the United States, the age of viability was at about 28 weeks. Babies younger than 28 weeks rarely survive. But and this was Roe versus Wade was the big Supreme Court decision that legalized it in the States. And this is why they picked a trimester framework, because viability was right around 27, 28 weeks. It was in the third trimester. Well, medical science didn't just stop. Over the last 50 years, our care of preborn human beings, of babies, has gotten better and better and better, to the point now that the age of viability is down to 22 weeks. Even World Health Organization recognizes that. So when you're doing abortions at 22 weeks and above, you're doing abortions on babies that could survive on their own with proper medical care. But we're talking about abortions up to about 24 weeks. The procedure we use most often, except for those few experimental things that are using drugs, is suction D&E. And I want your audience to understand what it's like, because I did suction D&E abortions up to 24 weeks. So I want them to understand clearly of exactly what we're talking about and why I feel about abortion the way that I do. Imagine for a minute that you're an obstetrician gynecologist like me. And imagine for a minute that you're a pro-choice obstetrician gynecologist like I used to be. Your patient today is 17 years old. She is 20 weeks pregnant. We're going to talk 20 weeks. Her uterus is all the way up to her umbilicus. She's been feeling the baby kick for the last 2 weeks. But now she's asleep on an operating room table and you're there to help her with her problem. Now, if you could see her baby, and that would be easy again on an ultrasound. Now, remember I said 12 weeks was the width of your hand? 20 weeks is the length of your hand. From the tip of your middle finger to your wrist, that is a 20-week baby, head to rump, not counting the legs, okay? A suction D&E abortion involves dilating the cervix for 24 hours or more to open it up sufficiently to do the procedure. And then putting a suction catheter, just like you do with a suction D&C, in the uterus. But this time, because the baby's so big, they can't go through the suction catheter. So all it does is draw out the fluid. And then you use an instrument called a Sofer clamp. I wish I brought mine along, but I didn't. But it's about 13 inches long. It's stainless steel. The business end is about 2.5 inches long and 1/2 inch wide, and it's rows of sharp teeth. It's a grasping instrument. When it gets a hold of something, it does not let go. So picture yourself taking that instrument and very carefully putting it up through the cervix into the uterus where the baby is, and blindly grab anything you can. And now pull. And I do mean really pull hard, and out pops a leg about that big, which you put down on the table next to you. And then reach in with that clamp again and grab blindly and pull hard. Out pops an arm about the same length, which you put down on the table next to you. And you use that same instrument again and again to tear out the spine, the intestines, the heart, and lungs. Now, the head on a baby that size, 20 weeks, is about the size of a plum. When I did, you can do it with an ultrasound, but I didn't. Most doctors don't use ultrasound for these procedures. You reach in with but you can't see it, but you reach in with your clamp. And if your clamp is around something and your fingers are spread as far as they go, you've probably got the head. You crush down on the instrument. If white material runs out of the cervix, now you know you got the head because that's the baby's brains. And then you can pull out skull pieces. Sometimes a little face stares back at you when you pull it out. So congratulations, you just successfully performed a second trimester D&E abortion. You just affirmed her right to choose. You just made $1,500 American in 15 minutes or more, depends on the clinic. That's what a second trimester abortion is, using a D&E technique. When you get past 24 weeks, now the babies are too big and too strong in terms of their body to be pulled apart like we do in a D&E abortion. And the bones start to calcify. So if you were able to break them, now you've got sharp pieces inside the uterus that could do damage to the mother. So you don't generally do a D&E abortion beyond about 24 weeks. That's about the limit. When you get past that, then there are various methods of doing an abortion. Again, there have been medical studies that are being done on using the normal abortion drug protocol, but in later pregnancies. That's still experimental. There is a technique where you take potassium hydroxide or digoxin, usually digoxin. And digoxin is a drug that's used to treat heart failure. But you have to be careful when you use digoxin, because the toxic doses are not too high above the therapeutic doses that make you better. Well, you inject large doses of digoxin into the uterus, and that kills the baby. It stops the baby's heart. And then you induce labor. That's basically what these later abortions are. I don't have the means to show it. In fact, if Pro-Life Ireland is interested, I will send you a video taken in, and it doesn't show the abortion, but taken inside a clinic in Albuquerque, New Mexico, because we talk about viability, but the political left in my country doesn't care about viability anymore. We're going to have abortion right up to the time of birth. And who cares if they're viable or not? They don't care. They really don't care. I will send you a video of a clinic that was shot inside of a clinic in Albuquerque, New Mexico, where they do abortions right up into the 3rd trimester. I know they do abortions at least as late as 36 weeks. We're talking just a few weeks from delivery. And you see, and you'll hear the conversation between the patient and the staff, the intake people, and the staff and the doctor. And you find out that at least in this particular clinic, they are performing this procedure. And then these women have to go through labor. In this particular video, which I will send you, and you should publicize, it's very interesting. The abortion is done at 27 weeks. And you know from listening to the call that this woman made to the clinic that this abortion costs $10,000 American, $10,000. And the patient is allowed to labor in a hotel room alone. No doctor. For $10,000, they can't afford to have a doctor or a nurse sit with her, take her blood pressure, watch her vital sounds, make sure that she doesn't hemorrhage. They can't afford to sit with this woman and be with her and provide care while she labors alone in a hotel room with no medical personnel and delivers her dead son or daughter into a toilet. This is what is being done, at least at this one clinic in the United States.
That's it's not incredible, but it's horrifying.
It is. It absolutely is. You know, I told you, yeah, you know, any feeling person, you do a 2nd trimester abortion, and I told you earlier, you have to keep inventory. You have to make sure that you get 2 legs, 2 arms, and all the pieces, because your patient will be in serious trouble if you don't. The first time you tear a baby this big apart with your bare hands and then go through those pieces, believe me, it strikes you. At least anybody who has any feeling at all, it's going to affect them. Now, I got used to it. As I said, you can get used, and a human being can get used to anything if they do it often enough. And it got to a point where it became more routine, at least up to a point for me.
You didn't perform 3rd trimester abortions, however.
I did not. No.
So am I from what you were saying there before, that after a certain point, simply because of the physiology, the anatomy of the baby, that certain kinds of abortion are just not possible? So
correct.
What you have, it's a form of feticide. You have to kill and then induce, shall we say, induce miscarriage, induce.
You're inducing labor.
And that's the standard procedure for 3rd trimester, or?
That is correct. You know, and that brings up another interesting discussion too. I did abortions in my training, and then I did abortions in private practice between 1980 and 1985, and then I stopped. Several years later, I went to work as an obstetrician gynecologist on the faculty of medical college, Albany Medical College in Albany, New York, at the Albany Medical Center, where I trained as a medical student. I came on staff as a faculty, and I was teaching medical students and residents. Now you will hear, and you heard this, I'm sure you heard this in Ireland from the pro-abortion people. We need abortion to save women's lives. Mm-hmm. Now, anybody with a brain knows that pregnancy can be dangerous. There are complications that can occur in pregnancy, and sometimes they are life-threatening to the mother. They do happen. Out of control diabetes, out of control heart disease, cancers. For 7 years, I worked at the Albany Medical Center on the faculty doing high-risk obstetrics. And I saw hundreds of patients with these severe conditions. And there often comes, and it can happen in pregnancy, there comes a time when the medical condition of the mother is so dire from complications of the pregnancy, we're talking about a wanted pregnancy, that you must deliver the child early. You must effect delivery early in order to save the mother's life. However, remember, the age of viability now is 22 weeks. The vast, vast, vast majority of the time, with few exceptions, that these kind of complications occur in pregnancy is after fetal viability. I worked for 7 years in a high-risk obstetrics unit at the Albany Medical Center doing high-risk OB, and I ended, as a pro-life physician, hundreds of pregnancies to save women's lives. I didn't, now see the word termination, I saw your eyes go up. They've stolen the word termination. You say termination, you think abortion. No, I'm using the word as English. I terminated, i.e. ended her pregnancy. I ended hundreds of pregnancy to save mothers' lives in 7 years. Now, how many babies did I have to deliberately kill in the process? Guess. None. Not a single one. None. Because they become viable at 22 weeks. And the vast, vast, vast majority of these complications occur after 22 weeks. Case in point, real case. I walk into the room, a mother is 27 weeks pregnant. She is 13 weeks premature. She has preeclampsia. Everybody knows, or most people know, a normal blood pressure is 120 over 80. Her blood pressure was 220 over 160. That's how bad her preeclampsia or toxemia was. This is simple. I have to deliver her. She's going to die. She's going to have a stroke if I don't. So I stabilize the patient and I do a cesarean section. I have her delivered in only half an hour. Okay? She did fine. The baby did fine. Now, remember how we have to have, especially late-term abortion, to save women's lives? Could I do a late-term abortion in that situation to save her life? Would that work? And the answer is no, because it takes 1 or 2 days to sufficiently dilate the cervix to allow the abortion procedure to be done. That's not a natural process. If I have a lady in this example with severe preeclampsia or toxemia, and I wait 1 or 2 days to treat her, she's going to be dead. You stabilize in all of these cases, you stabilize the patient, you do a delivery. If you have time, you induce labor, and if you don't, you do a cesarean section. And as I said, for 7 years, I did hundreds of these cases and never had to deliberately kill a single baby. Now, did every one of those babies make it? No, but they all had a chance.
Are you saying, in essence, that in these cases of premature deliveries, that
yes,
it was actually safer to deliver the child rather than abort it?
Absolutely.
The mother's health.
Absolutely.
Right. Now,
safer for the mother and for the baby. I mean, you get the baby out in that kind of, again, in that toxemia example, when the baby's in the uterus, even though he's 13 weeks premature, if you leave the baby in utero, the baby's going to die eventually. So you get the baby out to save the baby's life, and you get the baby out to save the mother's life. And in this case, as was usually the case, we saved both lives.
We referred just there to the methodologies regarding in the third trimester. I just wanted to bring up, there was a survey was carried out of doctors after a year of abortion being introduced into Irish hospitals, which was published in the British Obstetrics and Gynecology, the Journal of British Obstetrics and Gynecology. And what they reported and doctors in considerable distress. For example, their doctors who reported they were in late-term abortions, they were injecting the fetus's heart in order to get it. And one doctor reported that this felt like he was stabbing the baby. another doctor reported he felt nausea, traumatized. He went out and he got sick in the corridor. Doctors reported being worried what would happen to the babies that were born alive, that there were doctors begging for people that would give palliative care in the case of babies born alive. I'm sure I know this is something that you have been asked about before, but these are doctors who are obviously struggling with this experience. They're doing it from the belief that you said you had at the beginning, that you felt that this was an ethically neutral thing. This was a service you were providing, a healthcare service. First, two questions, I suppose. First of all, how, particularly in these cases, how does this affect doctors? Is this something, as you say, that over time it's like a callus that grows over the feeling and we become habituated? Or do we find, or is it that some doctors just simply leave the practice, that some people just can't, as it were, cut it? And what can we do, in a sense, to reach out to those, to speak to those people who are feeling traumatized?
Yeah.
Your own experience, or not necessarily your experience, but the experience of your colleagues that felt beyond discomforted, but traumatized, hurt, worried by the experiences of what they saw and what they were doing.
Yeah, I could give you a lot of stories. First, again, unlike Ireland, abortion has been legal in the United States for almost 50 years now. It's 48 years since Roe versus Wade, but states like New York legalized abortion in 1970. It's 51 years ago. So we've had it for a very, very long time. And yet, 3 studies have been done in the last 10 years about who's even willing to do abortions in the United States. And they looked at obstetrician gynecologists. And when you combine the 3 studies, the results are that 86% of all obstetrician gynecologists in the United States, and specifically 93% of obstetrician gynecologists in the United States in private practice, refuse to do abortions. There have been any number of physicians, and the number of abortionists in my country have been going down, down, down for years. And the other side is very worried about this. I can give you a specific example. A doctor that I worked with at that university was dedicated pro-choice doctor. He was my wife's gynecologist. And he had no qualms about it politically, and he did it as a service. He did it for years. But remember I said, when you do an abortion, you've got to look through the pieces. He had done them for several years. And one day, I don't know what it was, but one day he told me he was literally looking through arms and legs and just looked up and said, "What the hell am I doing?" And he stopped. That was it. Now, if you asked him how he felt about it, he probably said, "Oh, I'm still pro-choice," but he won't do the procedure, which is kind of interesting. I think this is a good thing, but I won't do it, is a kind of interesting attitude. Another doctor I knew at that university, long story, but one of the doctors there used to do abortions on a regular basis. He was Catholic, in fact. His daughter had heard a pro-life presentation in her school one day. She was 13, and she came home, and over dinner, her parents asked the question we all ask our kids: "What did you do in school today?" And she described how this woman had come in and gave a pro-life presentation. And then the daughter, completely innocently, talks to her parents, having no idea that her daddy did abortions, looked at her parents and said, "I just don't understand how anyone could do that to a little baby."
Oh, God.
Had no idea her dad did abortions. Her dad was so scared that his little girl would find out what he did that he quit, and he never did another abortion after that. In my case, I was doing abortions. I said I was dedicated to it. My wife and I met, we married, and I was telling you earlier, I'm 100% Sicilian, she's 100% Irish, and we always have interesting discussions together. But we had wanted children. We wanted a family. We both came from big families, and we couldn't. We had an infertility problem. And after an extensive workup, we were told that we probably would not be able to have children. And we were extremely fortunate, because it's very difficult to do, certainly in the United States, to adopt a little girl that we named Heather. As sometimes happened, after all that time trying to get pregnant, we adopted a girl, and then my wife got pregnant, the one and only time, and our son was born, and our son and daughter were just 10 months apart. But exactly 2 months short of my daughter's 6th birthday, she was killed in an auto accident. She literally died in our arms in the back of an ambulance. Now, anyone listening who has children may think they have some idea of what that might feel like. But if you haven't lost a child of your own, you have no idea what it feels like. I hope you never find out. What do you do after a disaster? You bury your child and you try to get back into your life. So I don't know how long it was after her death, but I showed up at OR number 9 at Albany Medical Center, just like I had over 100 times before, for a 2nd trimester D&E abortion, the one that I described. I wasn't thinking of this as anything. It was routine. I had other things on my mind. And I reached in with that clamp and I tore out an arm or leg like I described before. And I got sick. I mean, I just staring at this baby's leg in my clamp, and I know I just tore this off a baby. But once you start an abortion, you can't stop. So I finished that abortion and I went through all the pieces, and earlier I talked about stacking up body parts on the side of the table. And like I said, that's not to be spectacular or to gross people out. As I said, you must keep inventory. And after doing over 1,300 abortions at that point, and having done them for years, after losing my daughter, for the first time in my life, I really looked at that pile of body parts. And I didn't see her wonderful right to choose. And I didn't see what a great doctor I was helping her with a problem. And I didn't see all the money I just made in 15 minutes. All I could see was somebody's son or daughter. And it occurred to me in that moment, back then I used to make $800 for that abortion in 15 minutes. That was back then. And it occurred to me that, and of course, it never happens literally, but figuratively, it occurred to me that this patient had come to me, said, here's $800, kill my son or daughter. Now, of course, the patient never actually says that, but isn't that exactly what she's saying? And I was the kind of doctor that would look her straight in the eye and with no compunction at all say, sure, I'll do that. And once you see yourself in that light, doing abortions became impossible over time. It just became absolutely impossible. There's so many fights in the pro-life and the pro-abortion sides. Oh, it's not a baby. It's just a fetus. It's just an embryo. Mm-hmm. And while those are technically, scientifically correct terms, the way they're being used by the other side is they're using it to depersonalize that individual human being. So I use the term baby, I use the term embryo, I use the term fetus. You've heard me use all those terms in this hour. Mm-hmm. But when I'm talking about this issue, I use a term that is absolutely 100% correct all the time. That is your son or daughter.
And when you have this moment of catharsis or metanoia, or this change of heart, how long is it? Something that you carry with you? Is it something that took time? Was there a process that you had to go through?
Well, yeah, it does, and it can take a very long time. You asked earlier what maybe, like, for instance, what can pro-life people do? You'll never change a doctor's mind if you don't have a relationship with that doctor. Mm-hmm. But if you develop a relationship with a doctor, literally, seriously, take them out to lunch. You want to talk to a doctor about what they're doing? Invite them out to lunch. Okay, buy them dinner. Become a friend. It's not easy to do. Although I will tell you a quick story. Doctors do listen to their patients. Years after I stopped, when I was still doing abortions, years after before I stopped doing abortions, I had a patient come to me just as a routine patient for a gynecologic exam and a pap smear. And I had no idea she was pro-life, but she's my patient and I pay attention to what my patients say to me. This woman, when I was done with her exam, said, "Can I talk to you?" And many women will not tell a doctor what's really on their mind until they develop some level of trust. So when I sat her down and asked her what I could do for her, and she was very religious, she kind of blew me away when she went, "I've been sent here to give you a message that Jesus loves you. He cares about you. This is not what he intended for your life, to be an abortionist. Please stop." Well, this absolutely blew me away. No patient had ever spoken to me this way. And I had one overwhelming thought when she said that, and it was, I have to get this kook out of my office as fast as I could, and I did. A year later, she showed up for her routine OBGYN exam and pap smear. And when it was over, she said, "Can I talk to you?" And I, oh no, because
Yeah.
it's not like I never darkened the inside of a church before, but people who are very demonstrative of their faith always made me uncomfortable. And she said almost exactly the same thing. "I've been sent here to give you a message that Jesus loves you. He cares about you. This is not what he intended for your life, to be an abortionist. Please stop." Believe me, I remembered what she had said the year before. But in the intervening year, between those two visits, I had received at least 3 or 4 personal greeting cards mailed by her to my office, to me personally, with that message mailed on the card. One time during the intervening year, I arrived at my office and there was a plate of brownies on my desk with a message tied to the brownies. This woman had decided that she was going to evangelize. She wasn't trying to convert me to Christianity. She was trying to get me to stop doing abortion. And because I had a relationship with her, I listened. Now, that's ultimately, I stopped doing abortions because of what happened to my daughter. But that's an example of how you can build a relationship with a physician and make your point known.
We talked about a little bit about the effect that it can have on doctors and the psychic issues there. I saw from your website and from what you said, and your wife Cecilia has talked about this, that it doesn't just stop at the doctor, but the abortionist, it brings on. Could you talk a little bit about the effect it had on that, on your family and on your family?
When we met together, we found out pretty quickly that we were on opposite sides of the issue. I mean, I was a doctor who was very pro-choice, and I was doing a service for women, and I was very dedicated to the idea of doing abortions. My wife was pro-life. She was a nurse, and when she was training in New York, she was given the opportunity to assist doing abortions. She had absolutely no way she would have any part of it. We found out very early in our relationship that we were on opposite sides. And we made the biggest, most fundamental, stupid mistake that a couple can ever make together. Instead of discussing it and coming to some kind of resolution, we just ignored it. And that set up a pattern in our marriage that went way too long. We'd been married several years. We adopted our daughter. Our daughter was almost 6 years old, and then she died. And this was terrible. But see, the problem with that is, in our case, if you decide that you want to avoid talking about one important issue together, it's too easy for a couple to not talk about all kinds of important issues. And we were growing apart. That's not a good thing in a marriage. And when our daughter died, obviously it was a huge crisis. We were almost mourning separately. And I continued after that first abortion where I had pulled out the arms and the legs. I knew why I felt bad, and I knew I would get over it. So I kept on doing abortions for a few months after that. But I got into a blame game. It was the girls. I was feeling bad, but of course it wasn't my fault. It's everybody else's fault. It's the girl's fault for getting pregnant. It's the hospital's fault for allowing them. It's the nurse's fault for scheduling them. And I used to go into these literal rages. And I said, she's Irish. She self-expression is not one of her problems. And after a few months of that, she'd had it up to here, and she packed a bag and she was ready to leave with my son. And that's when, but as I said, she, self-expression is not one of her problems. She was going to have her say. And before she walked out, she looked at me and she said, "You know what? It's not the girl's fault for getting pregnant. And it's not the nurse's fault for scheduling it. And it's not the hospital's fault for allowing them. It's your fault. If you're feeling so bad about this, why don't you just quit?" That was the opening salvo, and that started a conversation between us. We talked for almost 2 hours together after that. For the first time after being married that long, we talked about the whole thing. We've been married 7 years at that point. And that was the first time that we really talked about abortion. And that's when I went to my partners the next day and said, okay, that's it. I'm not doing any more abortions.
Before we finish up, there's one last issue that I think is important that I'd like to touch on and get your views on. We now have legal abortion. In Ireland, there's a push now to legalize what is called assisted suicide based on euthanasia, basically. Do you think that in the context of a situation where in late-term abortions, we know there are examples, and they're not small in number globally, where children are delivered alive and then are left to expire without any care, without medical care, food, or hydration. And this is because, in a sense, it's their tough luck. I mean, if they had been a wanted child, they would be given all the care in the world. Does abortion change the way doctors practice medicine, or does its existence in a system change if, for example, we can say because a child has a certain disability or a certain life-limiting condition, that's a reason that we can abort the child. And even if the child is born alive, well, then we just leave it because we just didn't quite get there. At the other end of life, when we start to see people, very vulnerable people who no longer have autonomy, no longer have the capacity to protect themselves, do you think that there is a leakage in the when we stop to see life as being sacred and precious in this absolute?
I think that does happen. I think that societies everywhere have become so much coarser. We've all seen it over the last few decades. No respect for authority and a lot of the other things that happen. And I think that abortion has played its part in that. It's interesting. You were talking about euthanasia, for instance. Think about it for a minute. Children are not stupid. My wife and I would, in the past, would go talk to school groups. And many, many years ago, I might be in front of 20 or 25 students in a classroom. And I would say, how many students here are pro-life? And you'd be lucky if you saw 1 or 2 hands. As time went by, more and more hands went up. Kids are not stupid. They can see on the internet ultrasounds and pictures of babies, and they understand what's going on. They understand that they could have been aborted by their parents. Mm-hmm. Now, it's really interesting. If a child grows up with that knowledge, what happens at the other end of the spectrum? Now you, the parent, are sick and ill in a hospital, maybe facing death. Maybe you can't make your own decisions, and they're going to go to your family, including those children, and ask them, what should we do with mom or dad? I think that the easy availability of abortion and many other things in our society, it's not just abortion, has made the value for life go down as time gone by. And it makes it easier and easier to do those things. It's the legal justification for abortion, is, once you are a person, once you have rights, and you gain those rights when you are born, then you have rights as an individual in your country, under your constitution. Once a baby is born, that is not just a human being, that is a person under the law and has a right, which includes a right to medical care. So when you hear about these cases of children being left to die after they're born, people, that is murder. That is killing an innocent person under the law. That is murder. Technically, abortion is not murder. Abortion is always killing an innocent human being, but it is not technically murder. But when a child is born and they are not given care, that's murder. And that's what you're talking about. I think that it has abortion has had its effect up and down society because the value of human life has been cheapened and cheapened and cheapened over time. And it has many, many effects. It almost drove my wife and I apart in our marriage. We were able to pull it back together again. It affects the doctors. It affects the mom. We didn't even get into, there's a lot of research about that, what happens to women after abortion. Now, again, the pro-abortion side says, oh, it has no effects. There's no mental problems that come after abortion. Yet there's a lot of good data, most of it out of Europe, as a matter of fact, and Finland specifically, that shows that if you follow women who have had abortions and compare them to women who have had their children, who delivered their children, you find that these women who have had abortions have a much higher death rate from all causes over the next year or two after the abortion. I don't have the exact figures with me, but that data is out there. Abortion affects the whole society, and it definitely affects the family.
Right. Just there are two questions before, if I can impose on you. I was saying before we came on there that I was talking to a pro-life activist who has Down syndrome, and they were talking about, there was a case recently reported where, because the child in the womb had Down syndrome, that was a reason where the abortion could take place. And in that case, the child was actually presenting in the birth canal. So in a situation like that, how would they actually perform an abortion in that kind of situation? How would that actually be affected?
I don't have any experience with late-term abortion like that. Under the law in the United States, the child must be killed before it is born, specifically because of what I talked about before. If the child is born alive, that is now a person under the law, and if you kill that child, then it's murder. So for abortion not to be murder in the United States, the child must be dead prior to delivery. Now, you're posing a situation where the head is in the birth canal. If I have to kill that child before it's born, I would have to completely expelled from the mother's body. I would have to affect death in some way prior to the baby being actually expelled from the mother's body. Head trauma, cutting the spinal cord. There are things I could do before the baby is totally delivered to affect a, quote, abortion before the baby is completely delivered. But you're splitting hairs here. You're saying it's okay to kill the child before it's completely expelled from the mother, but it's not okay to kill the child 2 seconds after the baby's out of the body, because then it's a person. This is insanity, but this is what you're talking about.
Also, and this is our last one. I won't impose it anymore. It's a question that it's sort of in three parts, as it were. It's again about the issue of doctors who are involved in late-term abortions. First of all, is it the case that is it, as it were, some kind of a slippery slope that people move into late-term abortion, that people don't, generally speaking, they don't start doing, say, third trimester abortions, but move.
Some do.
And then.
Well, to answer that, there is, as I said, there is a push to get more, to make abortion more acceptable to doctors in the United States, to the point now that a new specialty has been developed to basically teach late-term abortion to residents who are just out of medical school, to get them to do second and third trimester abortions. It's possible that some doctors start with earlier abortions and move on to later abortions. That really wasn't true for me. I had the opportunity to learn second trimester abortions right during my training program. So I was doing first and second trimester abortions right out of the get-go. And now, as I said, there's even a medical specialty developed and training programs developed specifically to teach doctors to do second and third trimester abortion, specifically because they want more practitioners doing those later abortions. So some work their way into it, others are trained that way.
Part of it, so I suppose we're trying to get at it, is there is there a professional or social pressure on the doctors in to engage in these procedures, shall we say, or is it simply a question of choice that if they want to get out of doing these, you just walk away?
Of course, it's a choice. You always have a choice. This whole thing is supposed to be about choice. Yeah, in the end, the doctor does an abortion because he chooses to do abortions. And a lot of doctors then choose not to do abortions. I was one of them. You can always walk away. Now, I know of cases where, doing abortions isn't exactly the most noble area of medicine, shall we say. People that do only abortions, I mean, I can't speak generally, but what kind of doctor does only abortions all the time? I mean, I know the answer with, well, I'm dedicated to women. That's why I do abortion. Really? This is why you went to medical school. This is why you learned the medical profession, whose purpose is to treat disease and extend and improve human life. And then you ended up as an abortionist. But there are also cases of, I remember a physician who lost his license because of very poor practice. He used to do abortions. Then he lost his license. He became almost unemployable and ended up doing abortions full time because he couldn't do any other work, that he couldn't find any other work. At least he didn't make the effort to find any other work. That's any doctor can choose to walk away from abortions, and doctors are needed all over the world. So don't tell me that's all you can do. That's rubbish.
Your last word here tonight was to imagine you're looking out and watching here. We have maybe perhaps a nurse, perhaps a doctor who is involved in performing abortions, perhaps has been perhaps in another jurisdiction nearby involved in it, and they feel conflicted about it. They're feeling guilt. Is there anything you would say to them how you begin the process of recovering from the guilt that they might be feeling, or finding a path towards a greater sense of peace with themselves?
It's funny. When my wife and I speak in support of pregnancy centers and at other pro-life functions. We've done it for several years. And we inevitably run into situations, and it happens frequently when we're at these presentations, that women will come up to us and want to speak to us. And many times they'll want to speak to us because they had an abortion earlier in their lives, and they've been struggling with it ever since. And they're looking for some sense of support or peace because of that. And we've learned over the years that many people will find that peace and solace from family support, you hope. Many people will start to reach that peace or solace through a knowledge of God or getting involved with their churches. Many may find peace or support in other women who have had abortions. Rachel's Vineyard is an organization that's been out there for years that specifically supports women who have had abortions, and it's run by women who've had abortions themselves, so they know what's been going on with them. There are many ways that people will find that, but we often find that women who are troubled by their abortions may even come to a point where they realize that, for instance, in a religious sense, that God forgives them. But we find that the problem is they have difficulty forgiving themselves. There are many places that doctors and women who've had abortion can find support and solace. It takes time, it takes understanding, and that process can be hastened by a doctor who's given up abortions, or in the case of a patient, talking to another woman who's had an abortion. In the United States, and I know in Ireland as well, there are many pregnancy assistance centers that are set up that are there to counsel women, not only about abortion if they happen to be pregnant, but they are there to provide free counseling for women who are struggling with having had an abortion and are struggling with the aftermath in terms of what they're going through. And these centers are there free of charge in the United States, and I know they're in Ireland as well, to help provide women support who've gone through abortions, who are looking for, as you say, solace or peace about it. And it's a difficult process, but it can be done, and there is help out there. And that's true for the doctors and for the patients.
Well, I'd like to thank you, Dr. Tony Levatino. It's been fascinating, engaging. I would have to say maybe disturbing, but that's the nature of the discussion. Anybody that's interested, it's very simple. You can Google Tony. He has a website, and you can find out more about him and the work that he does. I'd like to thank you for joining us. I'd like to apologize to those to whom I didn't get to your questions. We had so many questions tonight, it wasn't possible. Again, I'd ask you to click on the subscribe button, and if you can help us to join in those battles, to defend those life values that we all share, anything you donate we will use to the best of our abilities. Thank you tonight. And again, Dr. Tony Levatino, thank you for tonight, and thank you for the work that you do day in, day out throughout the United States.
Thank you, Michael, and I'm very pleased to be able to assist Pro-Life Ireland. I was heartbroken when Ireland legalized abortion. I had spoken before the Citizen Committee, but I'm so grateful that you are there and doing the work that you are doing. God bless you all.
Bye-bye. Thanks, and God bless.
Bye-bye. Take care.